This message is for our legislative representatives who are shaping our much-needed healthcare reform. We strongly encourage you to redesign the hospital readmission reduction program. As part of the Affordable Care Act, this program is phasing in a penalty for hospitals whose patients are readmitted within 30 days of discharge. The intent of the program is to reduce waste and contain escalating costs, but we believe the design of the program is flawed. First, we will readily acknowledge that there is a problem with readmissions. 20% of all Medicare beneficiaries return to hospital within 30 days, and 2/3 of these readmissions may be avoidable. This is a $12 billion problem. Secondly, we will also acknowledge that there are many success stories where readmissions have been reduced. For example, the 2009 STAR Initiative and also Project RED, two programs that implemented care management services and reduced readmissions by a significant percentage. As you may know, beginning October 2012, over 2,000 hospitals incurred readmission penalties, and nearly 300 hospitals were penalized the maximum fine, losing 1% of their Medicare reimbursement. But were these penalties fair? We urge you to consider the multiple factors that contribute to readmissions that are outside the control of healthcare providers. A common thread in readmissions is the socioeconomic status of the patient population being served. This demographic and other related factors are clearly outside the control of providers, and it's therefore unfair to penalize our hospitals for these readmissions. Consider the correlation between socioeconomic status and the tendency towards readmission. The amount of penalty is directly proportional to the percentage of poor patients being served. The readmission penalty discriminates against providers who must offer care to lower income populations. Instead of applying a readmission penalty uniformly across all hospital settings, regardless of their demographic characteristics, why not focus on the top barriers to reducing readmission rates, like patient handoff, access to primary care, and access to hospice care, for example? So, in summary, we believe there are 3 important improvements that need to be made to the readmission penalty program. Number 1, revise the penalty to risk adjust for providers in socioeconomically deprived environments. Number 2, require providers to provide care management services to improve support and education across the post-acute care continuum. And 3, improve primary care services and other post-acute care services to manage chronic illness and complications. We urge you to reevaluate the current hospital readmission reduction program, and we hope we have given you some useful alternative structures to consider.